Okay, thank you and good morning, good afternoon, good evening po sa lahat. Saan man po kayong panig naroon sa mundo. Welcome to our 186th episode of the Health Updates webinar series. Thank you for being part of our credible online community. And to all those who've just discovered us for today, welcome po. At sana po marami po kayong matutunan about two neglected tropical diseases of the skin. And I'm talking about scabies, caused by Sarcoptes scabiei mite, and Yaws. It's a bacterial infection caused by Treponema pallidum subspecies pertinu. It persists as significant health burdens po in many regions, particularly in tropical and subtropical areas. So pag-uusapan po natin ang estado po niya dito sa Pilipinas. And despite prevalence and impact po nito sa mga komunidad, these diseases often remain overlooked and they have been designated as neglected tropical diseases. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institute of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And today, it's my pleasure and honor to host this program again with one of our program stalwarts po, si Dr. Stella Mariose. Ma'am Stella?
Good afternoon, Dr. Raymond, and welcome to all our participants here in the broadcast of the Zoom webinar, and to all of those watching via live streaming in the TVUP YouTube channel, in the UP System Facebook page, and also in the TVUP Facebook page, and of course, those watching from the TVUP Signal TV Channel 101. Today, we have our two speakers, Dr. Belen Lardizabal Doquitas and Dr. Rowena Hendino. Okay, so as you have seen in our opening billboards, our program is now called Health Updates. We have done a little reformatting for our program, and but still we are maintaining that high quality and level of leveling up to take a closer look at the existing and emerging health problems in the Philippines and in the rest of the world. For 2024, we want to get immediately to the heart of the discussion, so our program will now be shorter. But before we go to the presentation, Raymond will introduce our person on the street video.
Thank you, Ma'am Stella. So person on the street video, especially for those who are just joining us for the very first time, it's a way for us to determine the baseline knowledge of our audience members. For this particular POTS video, that's what we call the person on the street video, which is produced week in, week out by the TVUP team. The questions that we pose are as follows po, no? Nagkaroon na po ba kayo ng infection sa balat? Alam nyo bang kailangang pagkukulan ng pansin ng ating mga balat? Alam nyo ba kung ano ang scabies o yung tinatawag na galis-aso, kagaw o hanip? Nagkaroon ka na ba ng ganito or may kakilala ka pang nagkaroon ng ganitong infeksyon? Paano nyo masasabing may ganoong kondisyon ng isang tao at paano nyo po ito ginagamot? Pagdating naman sa Yaws, alam nyo ba kung ano ang Yaws? Nakakita ka na ba ng taong may ganoong kondisyon? Please watch this.
Yes po.
Oo, nung bata.
Opo. Nung isang taon po.
Pag nag-uukulan ko lang ng pansin pagka nakita ko na parang ano siya. Kasi dati parang nagkaroon ako ng yung parang bumi siya. Ganun. Tapos parang kumakalat. Kaya, syempre pag nakikita mo na yun, syempre aanin mo na kung paano siya gumano.
Galis, oo. Kasi nung bata, meron ako niyan. Ako, kapatid ko, mga pinsan ko, yan.
Nung isang taon po, nakakontract po ako ng hand-foot-mouth disease. Dahil dun po, medyo nagkaroon po ako ng lesion sa balat.
Kapag Makati, nagkakamot, may mga sugat.
Yung parang yung balat niya yung balat niya parang nagsusugat o yung parang namamalat na nagsusugat. Di ba yun yung hindi ba?
Para sa akin pananaw, kapag nagdudugo na, kapag nagkakaroon na ng flakes, kapag siguro meron tayong nararamdam na walang katapusan na pagkakati.
Nung bata ako, naalala ko yung mother ko. Nagpapakulo siya ng dahon ng bayabas. Tapos yung pinagkuluan, bababad mo yung kung saan may galis o sugat, minsan tinatapalan ng dahon na pinakuluan.
Meron pong rin-recommend yung tita ko na parang Madre de Cacao. And para sa mga kasama ko, hindi ko lang po alam yung specifics, pero parang linalagyan nila ng moisturizer yata o pampahid sa balat para i-treat ito.
Hindi ko rin alam.
Hindi ho, ngayon ko lang narinig yan.
Para sa akin pala na yung yaws ay parang infection din sa balat. Opo. At wala pa ako nakitang tao mismong may yaws at sana hindi. Para hindi ko makontract.
Sa aking karanasan, kapag may sugat na, namumula o dumudugo na, kailangan bigyan na ng pansin yan.
Okay, thank you so much, TVUP. So, ano po, no? Very important since we're talking about neglected tropical diseases, may hindi pa po nakakaalam or nakakakilala ng iba pong mga sakit sa balat. So, it's something that we'll need to be mindful of for our webinar for today. What did you think of the video, Ma'am Stella?
Oo, ang ganda ng video kasi parang lahat ng their honest to goodness thoughts on Yaws and also Scabies. So thank you TVUP for letting us know what the people on the street are thinking. And I think yung certificate yata, Raymond, mention mo.
Yes, opo. Certificates of attendance po, no? Reminder again, will be given only to those who have watched at least 50% of the webinar duration. We are happy to inform everyone that we've released all of the certificates for all 185 webinars. We have been scouring po and slowly responding to each and every email message po, especially for those asking if they could receive their certificates, just trying to double check po, no, if they really fall within the criteria that we have set. For webinar today, we'll be having a standard panel discussion format, and after our speakers have presented, that will be followed by a quick Q&A session. So without further ado, we'll get the webinar rolling. Ma'am Stella will introduce po our very first presenter.
Our first speaker is Dr. Rowena Hendino. She is a professor at the UP College of Medicine and the Department of Anatomy. And so, folks, let's all welcome Dr. Rowena Hendino.
Good evening to everyone. Can you see my slides?
Yes, ma'am. If you could go to slideshow.
Okay. Yeah.
There we go.
There.
Okay.
Okay. So again, thank you to TVUP for the invitation to talk on this topic that's close to our hearts as dermatologists. And so scabies, how to end the neglect in the Philippines. So I have no conflict of interest, although this topic is my research for my dissertation. So I have 3 objectives for today: to highlight the burden of scabies in the Philippines and its impact on public health, to describe a typical scabies case and how it is transmitted, and to provide actionable strategies for containing and managing scabies in our country. So in 2017, the WHO has included scabies in its array of skin-related neglected tropical diseases. And there are 9 out of the 20 that are considered NTDs. So these are diseases of poverty, which are perpetuated because of the populations that are affected. So scabies is one of them, and Yaws is also another. And leprosy, which has a control program in the Philippines, is the most, I think, famous of them all. So the global prevalence of scabies is about over 2% according to the Global Burden of Disease, and it affects around 200 million people. It is the second highest among the skin diseases in the Philippines in terms of disability. The first is dermatitis. So there is a varying prevalence in the Philippines, from a low of about 2% in community surveys up to a high of 58% in crowded settings such as detention facilities. So in the Philippine Dermatological Society database, we have around 5% in our outpatient consults. So the severe itch, as one of the persons on the street mentioned, walang katapusang pagkakamot or pagkakate is the hallmark of scabies because that is the reaction to the presence of the mite is the one that really bothers the patients. It affects work productivity, school performance. It creates stigma and problems with relationships. It also has an economic burden, especially in large households and multifamily households. And more than that, there would be secondary complications such as bacterial infections, which may even lead to death, and some post-infectious complications down the road, such as glomerulonephritis or rheumatic heart disease. So in 2022, there was an increase in the number of cases of scabies, particularly in Bukidnon. So there were around 5,000 plus cases, and this actually triggered the DOH to come up with an interim guidance in 2023. So these are the mountainous regions bordering Bukidnon, Agusan del Sur, and Davao del Norte, where these cases were increased. So how is scabies, how does it present and how is it transmitted? So the female mite, which is an eight-legged mite, burrows into the skin. And when it lays its eggs, it also releases some fecal pellets, which causes a hypersensitivity reaction that causes the itchy rash. The locations of the burrow usually involves the skin folds between the toes and the fingers, the wrists, the buttocks, and the genital area. So the transmission is by skin-to-skin contact, usually prolonged in the house between sexual contacts. And it spreads easily, especially in closed settings, institutions such as prisons and aged care facilities. And because of the itch, there's scratching, and which leads to bacterial infection, such as impetigo, and even more serious complications in the long run. So this is the typical, aside from the burrows that are actually difficult to find unless you are a well-trained observer, the typical lesions would be papules, sometimes vesicles, which are distributed in the folds of the skin. So in an adult, it also includes the genital area. In the infant or in the child, it may involve the scalp as well. So in these pictures, you would see that some of them are crusted because of the secondary bacterial infection. So to formalize the diagnostic criteria, in 2020, there was the International Alliance for the Control of Scabies came up with 3 levels of diagnostic criteria. The highest level is the confirmed scabies using microscopic or other imaging techniques. However, these are only used usually in the clinical trials or when there is an atypical case of scabies. So otherwise, we can content ourselves in our clinics in the community setting with just the clinical and suspected scabies based on the history and the physical examination. So it is common to have a misdiagnosed case of scabies. So as I mentioned, the most common disease causing disability is dermatitis or eczema. And scabies can be misdiagnosed as such because of the itch and the rash. So that's why sometimes, because these are treated with topical steroids, they may end up as crusted scabies, such as in this case. So in this case also, the same case, microscopic scraping gave the diagnosis away as scabies by the presence of this mite and the eggs. So in Bukidnon, it was also a diagnostic dilemma to differentiate it from hand, foot, and mouth disease because they both present with palm and sole lesions. However, usually in HFMD, there would be fever, flu-like symptoms, and oral mucosal lesions. And usually the lesions are not excoriated because they are not very itchy or not as itchy as scabies. So you see here the vesicles that dot the extremities, including the palms and soles, in hand, foot, and mouth disease. So pyoderma hiding scabies underneath is a common thing, so that sometimes you will treat the pyoderma but not the scabies, and thereby the transmission continues. So again, topical steroid misuse may lead to crusted scabies, as in this Filipino 2-month infant, which was treated, who was treated with topical steroids for an ordinary so-called heat rash, but which turned out to be scabies. So leprosy can occur with scabies because of the, deficient immune system, and they are really co-endemic entities. So here is a case of leprosy with grade 2 disabilities with superimposed crusted scabies because of, again, being treated as eczema for a year before the diagnosis of scabies was done. So how do we treat scabies? So really the challenge is multi-dimensional because there are socioeconomic determinants to health, and scabies is not exempt from that. So poverty, overcrowding, vulnerable populations, lack of access to healthcare, delayed diagnosis, lack of health-seeking behavior, deficient public health care system, scabies not being a reportable disease in the Philippines. It's not part of the universal, it's not part of the coverage of PhilHealth. So there is really no way that patients can really expect anything for the management of scabies as of the present time. So how do we treat scabies? First, we have to treat the patients who are infested and the community, so and the household. And if the patient is in a closed setting, of course, we have to also treat all the contacts in that setting, because we have to control the transmission, because it's a highly infectious disease, and the vulnerable populations are the children and the elderly. So because of the delay of symptoms due to the inhibition of the immune system by the scabies mites, there is a need to treat even asymptomatic contacts. Another problem with treatment of scabies is that even if the mites are successfully eliminated, there would be some itch that persists due to the hypersensitivity reaction to the mite or its products. So this is something that we have to address as well by giving antihistamine, topical steroids, or even just emollients. So the life cycle of the scabies is important in determining what to give the patients. So when the adults mate on the skin, the female mite, pregnant mite, now digs tunnels into the epidermis and lays eggs, so 2 to 3 eggs per day, and then it hatches into the 6-legged larvae, which eventually find its way out into the skin surface again, transform into the nymphs, and eventually into the adult, and then the cycle begins. So the treatment would depend on what stage of the life cycle you are targeting, because if you are targeting both the eggs and the adults, you have to get an ovicidal drug, and a single dose would be enough. However, if you are giving a non-ovicidal drug, you have to give it twice, so that a week or 2 apart, so that you also catch the newly hatched eggs from the eggs. So in the Philippines and most of the countries worldwide, permethrin would still be the standard of care, applied topically to the whole skin in 2 doses, 1 week apart. However, compliance is quite difficult because of the challenge of applying to the whole body and the cost. So oral ivermectin is an option that has been recommended by the WHO for mass treatment of scabies, and it's included in the essential medicine list. Actually, it's being used already first line in some countries and second line off-label in a few other countries. However, in the Philippines, although it was available for a short period of time during the COVID pandemic, now it has its registration has expired, and actually they are just using up the stocks in the drugstores. Combination has also been used, especially in Austria, wherein it is part of the epidemic to counter to what they call they have an epidemic of scabies, and so they are recommending the use of the combination of both the oral ivermectin and permethrin. So the cost of oral ivermectin is a fifth of that of topical permethrin, which makes it ideal for a settings that are resource limited. So this is an economic evaluation we did, published early this year, showing that ivermectin-based regimens are likely cost-saving compared to permethrin in our setting. So how do we prevent and control the spread? So there are several frameworks and there's some guidance, but in general, we still have to rely on local criteria or local strategies for controlling scabies. So in 2019, after a WHO informal meeting, which Dr. Belenda Fitas attended, they came up with a framework for scabies control. However, there is no formal guidelines yet from WHO as of the moment. So in this framework, we start with the mapping of the disease burden. So based on reviews, you now do rapid mapping of hotspots prior to doing a nationwide prevalence survey, which will enable you to now fashion or create the appropriate treatment control program. So if the prevalence is more than 10%, an ivermectin-based mass treatment is recommended using 200 micrograms per kilogram of oral ivermectin in 2 doses in 3 to 5 annual rounds. Now, if the prevalence is moderate, between 2 and 10%, there are no clear recommendation. So there is strategy-based programs that would depend on the local factors. Monitoring and evaluation should also be done between MDA and impact assessment to determine if the program is working and if the prevalence has gone below the stopping threshold for MDA, which is 2%. So again, we consider all other factors, and in the Philippines, access to medications, particularly ivermectin, is one of the issues that we have to address. So this is the interim guidance by the DOH in 2023, which also recommends permethrin as the first line, and notes that oral ivermectin is being used in other countries, but at the moment it has expired its registration. So still, it has a role as an off-label drug for scabies, especially for those who have failed topical treatment or contraindicated for topical treatment, or have crusted scabies, or in closed settings where logistical considerations are important. So this MDA systematic review of MDA shows that although there were only a few studies and with a high degree of heterogeneity, there was an overall reduction in scabies prevalence by 79%. And although they were comparable for ivermectin and permethrin, ivermectin is the one recommended by the WHO. So interestingly, impetigo was also reduced just by treating scabies. So it's highly effective in reducing the prevalence of both scabies and impetigo. However, the settings in these studies were mostly island settings, and so it has to be tested in other settings and in larger populations. So these are the countries where those MDA programs are being done, mostly in the Pacific Island Rim. So a global call was recently called to tackle skin entities. So it's not just scabies, but all the skin entities considered altogether in a cross-cutting approach. So the cross-cutting approach is not disease-specific, but it would be either intervention-specific or those that fall under a similar disability or similar public health measures. So there is integration across many areas. So an example with that would be the Fiji algorithm of screening, wherein nurses they tested the sensitivity of diagnosing infected versus non-infected. And infected scabies had a higher sensitivity versus the pediatrician diagnosis. Still, it shows that screening can be cross-cutting as well and integrated so that you will also catch not just scabies, but other skin entities. And the simplified criteria, it was used by community health workers in 3 Pacific island countries. And so history is not that important. And there was limited examination only to the skin exposed areas. And again, there was no specialized equipment, but just examination by a health worker. So there is a skin NTD guide app that you could download in your mobile phones, and it will show you the different skin entities, including scabies, and there are pictures there, and there are some notes, even prevalence you can see there. And actually, for the Philippines, you can see that we only have data for leprosy. So the others, we do not have data. So what do we recommend for practice and policy? So first, because of the misinformation or misdiagnosis and the need for good compliance with medication, we have to educate our patients. We also have to train physicians especially in drugs that are less commonly used. For example, ivermectin. In acceptability study that we did, we found out that the physicians have little awareness and are sometimes lack confidence in prescribing ivermectin. There would also be a need for local CPG, although there are international guidelines. What we have is just an interim guidance from the DOH. And of course, monitoring and pharmacovigilance, especially in the use of ivermectin, which has been much maligned, especially during the COVID pandemic. So, but to be able to do that, we need regulatory approval, and it should be also considered for HTA priority topic and inclusion in the formulary. So, a comprehensive scabies control program, inclusion in the universal healthcare program, cross-cutting approaches for all skin entities are a must. So as a summary, there would be a need for raised awareness among health professionals regarding the prevalence and impact of scabies, and we really need to document the prevalence in our community and in our country. We also need to be aware of the different presentations of scabies so that we don't misdiagnose it, and to familiarize with how it spreads within communities and especially closed settings. And then we should equip professionals and policymakers with evidence so that they could have practical strategies that would contain and manage scabies in the country. So with that, I would like to end my presentation. Thank you very much.
Thank you so much, Dr. Genuino. Very important po, no, especially for the 3 main key points that Dr. Genuino mentioned. Dr. Stella, any reaction?
Yes, I'm very impressed with the presentation of Weng. No? So, meron pa siyang sarili niyang study. No? You know, that's really quite rare for our speaker na siya yung main author of the paper. And we're really happy that you presented your findings here in TVUP. Maraming ma-enlighten dyan sa talk ni Weng. So nakita natin yung person on the street, hindi nga nila alam what is kung ano yung mga skin illnesses na to. And these are really neglected tropical diseases. And we should be more aware of this. No? So thank you, Weng, for your presentation. And Raymond.
Thank you po. Thank you, Dr. Weng. Just to remind everyone, we are encouraging you to put in your questions po dito po sa ating Q&A box. So we're seeing a few phone-in questions, so to speak, but we encourage everyone to put in your questions here in the Zoom Q&A and also in the Facebook pages po natin for TVUP at saka sa UP System Facebook pages. For our second main presenter, So you probably are very familiar with her. She's trained po, no, and is a fellow of the Philippine Dermatological Society, but also has a master's degree in clinical epidemiology and a doctorate in public health from the Erasmus Medical Center in Rotterdam. With this particular topic as her ano po, no, dissertation. She is faculty and the section chief of the Skin Neglected Tropical Diseases at the Department of Dermatology of the Philippine General Hospital. Please welcome to your screens Dr. Belen Dofitas.
Hello, good afternoon, everyone. Let me set up my screen first. This is the hard part. Yes, we have to share again once I go to presenter view.
There we go.
Wait a minute. Is it presenter view now?
We are seeing your notes lang po, ma'am.
Okay. I did it earlier. Okay, this is it. Okay. There.
There we
Full
go.
stack. Okay. Thank you very much. Good afternoon, Raymond and Stella. Pleasure to be here this afternoon. And my topic actually is really an unknown topic. And I'd like to start with this Filipino proverb, bihirang masilayan, agad nakakalimutan, seldom seen, soon forgotten. So this is a story about a disease that has been forgotten but found anew. Today, I'm here to make sure that you do not forget about Yaws in the Philippines. So as disclosures, I was commissioned by the Philippine Department of Health to conduct 2 epidemiological studies on Yaws. Currently, I'm a technical expert being consulted by the Department of Health for Yaws and leprosy, and I have no commercial conflict of interest. I will describe what Yaws is, the status of Yaws in the Philippines, how to recognize and treat Yaws, the lessons learned, and the way forward. So what is Yaws? Yaws is a tropical, highly infectious chronic disease of the skin, bones, and cartilage that mainly affect children in remote and impoverished villages. It is passed on through skin contact and is not sexually transmitted. So poor environmental and personal hygiene promote it. It's caused by Treponema pallidum subspecies pertenu. And this is an organism that is closely related to the cause of syphilis. There are 3 stages of Yaws, just like there are generally 3 stages of syphilis. As with syphilis, we have a primary or mother yaw. So it's just a single lesion. So these are bumps on the skin and they're pinkish. And these are acquired during childhood. So after a few weeks, the secondary stage occurs with numerous daughter yaws. So these are the infectious stages. As long as there are skin lesions, the person is infectious. Latent yaws also occurs between flares of secondary yaws, but there are no active skin or bone signs. Now, adults may also have latent yaws. Okay? So this is another form of secondary yaws where it's whitish rather than pinkish. Now, the tertiary or late stage of yaws is considered a non-infectious state, but this is where you have the chronic deformities. Now, why is yaws important to find and to treat? Because if it is left untreated, around 10% of yaws patients develop chronic skin ulcers or bone and cartilage deformities, like the ones you see here. No? Gangosa on the face, saber shin on the leg, and swollen joints of the fingers or toes. Now, it is also estimated that for every Yaws patient in the infective stage of disease, there are actually 10 other patients with active disease hidden in the village and 30 others with latent infection. How is Yaws diagnosed? We should at least have the typical signs and the blood tests. Now, Yaws has a pinky, bumpy appearance similar to raspberries, or it can have a moist yellow mushroom look. So there should be a combination also of the skin signs in a person who lives in an area where yaws is known to exist. And also, there must be low risk factors for syphilis. Now, blood tests are needed to detect treponemal and non-treponemal antibodies. So, if both treponemal and non-treponemal antibodies are detected, the person has either active or latent yaws. So, how widespread is yaws in the world? As of 2021, there are 15 countries that are known to have yaws. The Philippines is the 14th country to be declared endemic for yaws in 2017. Since then, Liberia became the 15th country, but in 2021, Malaysia reported a confirmed yaws case. India is the only country that was certified as free of yaws transmission in 2016. There have been over 100,000 suspected yaws cases reported by 13 countries. However, the status of yaws in 76 previously endemic countries remains unknown. Yaws was widespread in the whole Philippines during the Spanish and American colonial times into the 1900s. 100 years ago, in 1922, Dr. Perpetuo Gutierrez, the father of Philippine dermatology from the University of the Philippines College of Medicine, was assigned to head the country's yaws control program. Yaws was a public health problem in several tropical countries like the Philippines in the 1900s. The World Health Organization and UNICEF funded a worldwide eradication campaign using injectable penicillin for treatment. In the Philippines, a trypanomatosis control program ran from 1950 to 1964. The number of cases dropped from 8.2 to 2.4 by 1960. Yaws was generally thought to have been eradicated, but some cases remained, spreading yaws again. Interest and funding declined. And after 1973, yaws ceased to be a notifiable disease in the Philippines and was forgotten. How did I find yaws in the Philippines? I found yaws completely by chance in the year 2000 when I conducted community skin surveys in villages that were known to have leprosy in the southern Philippines or Mindanao. On my first day, the local health workers asked me, "Doctora, have you ever seen yaws? We have a lot of cases here." So as a dermatologist, I was both surprised and excited to have found a disease that was thought to have been eradicated. At that time, I really did not know anything about yaws, except that it was one of the non-venereal trypanematosis. I reported the presence of yaws suspects to the Department of Health, but there was no program for it at that time. Yaws is called bakataw in Maguindanao, and it used to be called bubo among the Tagalogs. Then in 2012, the WHO earmarked yaws for eradication. Countries that had yaws but stopped reporting it were encouraged to find out if yaws was still present. Fortunately, in 2013, 13 years after I encountered yaws, the Philippine Department of Health commissioned me to confirm if yaws was present in the country. The first study surveyed 9 randomly selected public schools in 3 provinces where yaws suspects had been previously cited in Liguasan Marsh, Mindanao. The second study looked for yaws in 5 selected remote villages and those with indigenous peoples in the Luzon and Visayas island groups. So my thesis is based on these 2 yaws studies. In order to find this forgotten disease, I examined historical records and focused my search for yaws in remote and impoverished villages. Our team interviewed locals and educated them about yaws. So we showed them lots of photographs. We conducted community screening for any skin problem, especially among children. And then we did the blood tests on yaws suspects. So those with confirmed yaws, household members, and health workers were interviewed about the effects of yaws on their lives. All patients were treated for skin diseases, and all yaws cases and close contacts were treated with 1 dose of oral azithromycin. I also tried to crowdsource for any information on yaws from dermatologists, other physicians, and health centers. Using electronic means, I showed them images of Yaws and asked them, have you ever seen Yaws? They were requested to report any Yaws suspects to me as well. In summary, a total of 3,018 children and adults from 14 study sites were examined for any skin disease during these 2 Yaws studies. In the first Yaws study, active Yaws was confirmed in 4 children and 5 out of the 9 study sites. In the second Yaws study, active Yaws was confirmed in 4 children and 1 adult. They were all found in one village of indigenous people in Luzon Island Group. A total of 33 Filipinos were found affected by Yaws. 9 active or infectious cases, 10 latent or potentially infectious cases, 14 past Yaws, 1 child with Yaws bone deformities, and no tertiary or advanced cases were found. The Yaws 1 and 2 studies sampled only 14 sites in the Philippines from Luzon to Mindanao, but we still were able to detect Yaws, first in Mindanao and then in Luzon. Yaws may be a relatively rare disease in the Philippines, but this is because it is forgotten and not recognized clinically. Thus, it is underreported or not reported. Through exploratory surveys where I crowdsourced for information on Yaws and I requested health personnel to report Yaws suspects to me, I found out that Yaws has indeed been forgotten. Only 3 dermatologists had ever seen Yaws in their lifetimes. Our physicians could not recognize it, and majority had no information about Yaws. So then, how do you recognize a skin disease that you have never seen in your life? Yaws has different appearances. You have to look closely and learn. Here are some of the first Yaws cases I saw in Maguindanao 22 years ago. This is a primary or early Yaws skin lesion. It's papillomatous or bumpy, and it's large. This 1-year-old baby was studded with moist cauliflower-like and yellow crusted nodules, plaques, and papules all over. This is our first confirmed case of active Yaws in 2017, a florid case of moist cauliflower and raspberry-like tumors on his armpit. Another boy had a moist cauliflower-looking yaw above his lip. Yaws can also appear as dry bumps and wounds, especially on the arms and legs. Other children had dry whitish bumps and patches. Yaws also affects the soles of the feet, creating painful wounds. We found the first case of Yaws bony deformity in an 8-year-old Aita from Luzon region. He had Yaws skin lesions and bowing of both forearms that developed over the past few months. Now, there are many differential diagnoses of Yaws, or maybe what we call mimickers, seen in this list. But of course, the most important differential diagnosis would be syphilis. So let's focus on syphilis because it is closest clinically and serologically to Yaws. Now, positive serological tests for treponema and non-treponemal antibodies would make us suspect syphilis as the most likely cause. However, we should keep Yaws as a possible cause of these positive blood tests now that our country has confirmed Yaws cases. When testing for Yaws, rapid tests that only require finger prick blood are practical and useful. One must remember that the blood of Yaws patients reacts similarly to blood from syphilis patients. Among older teenagers and adults, syphilis may be possible since they might be sexually active. So for this reason, this is why children are the focus of Yaws screening and confirmation because syphilis is less likely among children. Polymerase chain reaction or PCR can distinguish between syphilis and Yaws bacteria, but this test is not readily available. I found another dimension to the problem of Yaws in the Philippines. Yaws is not only a physical problem. It does not only affect children, but all stages of life. It has lifelong socioeconomic consequences. Now, among children, Yaws is mainly a physical problem. but can lead to teasing due to its unpleasant appearance and smell. Among adult participants in Mindanao, Yaws was considered a stigmatizing disease due to the persistent positive treponemal blood tests associated with syphilis and also associated with promiscuity. This has led to loss of work opportunities due to rejection from overseas employment. Now, what is the treatment of Yaws? Actually, it's quite simple. Yaws can be quickly cleared using 1 dose of oral azithromycin, as seen in this child we treated way back in 2017. However, reinfection may occur. The eradication strategy therefore entails the treatment of the whole community, followed by monitoring and additional rounds of treatment if necessary. So this is the eradication strategy called the Morges strategy, endorsed by the World Health Organization in 2012. For 1 dose azithromycin in adults, you give 2 grams. For children, 30 milligrams per kilogram up to 2 grams. Now, only the confirmed Yaws endemic villages should receive this kind of treatment. It can be a total community treatment, the entire community. It can be what we call total targeted treatment, where all active clinical cases and contacts, like the household contacts, for example, are the ones being treated. So what are the next steps? Due to the evidence from the Yaws studies, Yaws is now one of the priority multiple diseases for elimination in the Philippines by 2030. That's the good news. For the villages already known to have active Yaws, there should be eradication programs, continued case detection, and community treatments. Water, sanitation, and hygiene are also essential for Yaws eradication. They are easily killed by soap and water. For the whole country, Yaws will soon be a notifiable disease once more, and active surveillance will be established. We have to increase public awareness, training of health workers, and have the necessary blood tests and medicine. A community skin health approach is recommended to detect hidden cases of Yaws and the other skin-neglected tropical diseases. So let's remember that the numbers of Yaws may appear low because Yaws is really underreported. It is hidden, unrecognized, and neglected. But it only takes 1 active Yaws case to spread this disease rapidly to more children. With your help, Yaws will be neglected no more. Thank you for your attention.
All right, thank you so much, Dr. Belen. Very important. I'm personally, ano po, no? Just an eye-opener for me. First time to hear about those things. Ma'am Stella, your comment?
Yes, oo. Galing ng lecture ni Belen. Oh, I'm impressed because sa kanya, grassroots level, talagang pinuntahan niya yung mga villages. You know, for a researcher, kaunti lang yung alam kong gagawa ng ganyan. Usually, they will just get the data from others. Pero kay Belen, sincerely, she wants to cure these people. I congratulate you, Belen, no? Besides your PhD, na nandun pa rin tong Yaws. You know, people should know more about it. That's what I think, no? Kasi, biro mo, even dermatologists, some of them don't recognize Yaws. Sila na nga yung considered specialists for this. So, I think we have questions from the floor, no? So, let us go to our questions.
Go ahead,
Raymond?
ma'am. Sige, go ahead with the first question, ma'am.
Ang question ko, kasi sinabi mo sa Yaws, azithromycin ang drug of choice. Kasi hindi ba pagka syphilis, usually we use penicillin G and all that. Paano na-discover na dapat AZ?
Yes, in the past, injectable penicillin was used, no, for the treatment of Yaws, and that was way back in the 1950s into the 1960s. But then it was discovered, and this was through a large randomized controlled trial, that 1 dose of oral azithromycin had comparable efficacy to also 1 dose of injectable penicillin. So with this finding that they had over 90% treatment efficacy. Yes. So that's why the WHO decided that Yaws can be eradicated, because now logistically it will be simpler because you
Oo.
don't have to inject anymore, not so much paraphernalia needed and resistance. You just have to give an oral dose. So
Yung,
that
oo,
is proven through clinical trials already.
yung minention mo for children, 30 milligram per kilogram body weight until anong age ngayon? 2 years old?
No, up to 2 grams ang maximum dose for a child. Yan.
Okay.
So I think children here can be considered up to 18 years old, no? But so it really depends also if it's the 18-year-old can be given the 2-gram dose, just like an adult. They're big and
Yes. Oo. Thank you for that. Raymond, you have a question?
Sige, ma'am. Very interesting question, pero it comes from Anonymous. This is for ano, no, for Dr. Inuino. What is the youngest age a doctor can prescribe ivermectin, ma'am?
Naisip ko rin yan itanong. Sige nga, Weng, ano ang answer doon?
So, children below 15 kilos cannot be given ivermectin tablets. Okay, so roughly around 5 years old, depending on the race. So in some settings, they don't have weighing scales, so they just measure the height. So 90 cm is the cutoff if they were going to use the height.
Sige, I have a question for Weng. Bale, in the pictures that you showed, may mga parang bumps lang in the hand, no? And then, pero in your presentation, it's like a total body, meron sa genital area, meron sa armpit, gano'n. So, first, it starts in the hand. Yun ba ang primary? Yun ang unang-unang nagkakaroon ng scabies?
Yes, that's the most commonly involved, the webs of the fingers and the
Webs.
toes.
Oo. So, what
And
is the
then
close
on-prem.
differential for kasi
I
parang medyo common siya kung titignan mo yung
Yeah.
picture.
Oo.
Oo.
So the common differential would be dermatitis actually because it's itchy, it looks like a
Oo.
rash, it looks
Oo.
like an allergy. That's why it's almost always misdiagnosed at the start.
Okay. Thank you very much for that. Ang ano kasi, parang napaka-common kasi, Raymond, yung parang bumps in the hand, no? So parang you'd think na, ito pala, scabies pala to.
Yes,
It
ma'am.
could look
Opo.
like a heat rash actually.
Oo nga.
Biliaria rubra can also be
That's why
misdiagnosed.
dalhin mo dapat sa dermatologist. I mean, they would know more about it. Yes, sige.
Ma'am Weng, if it's younger than 5 years old, ma'am, ano po
So
ang
younger
binibigay?
than 5 years old, you could give permethrin. That is the standard of care. Topical permethrin, 2 doses, 1 week apart.
2 doses, 1 week apart. Okay.
In some countries, they still give benzyl benzoate. It is cheaper, but it's not available locally. We have sulfur, so sometimes if the cost is an issue, sulfur can be a alternative. And also we have some herbals that can be used. So Acapulco, Makabuhay, Cacahuate, those are local herbs that can be formulated. And the Institute of Herbal Medicine and Dr. Dafitas actually participated or initiated those trials in the 1990s. And Acapulco lotion was actually here in the market for a short while before it was, taken off because of lack of, I think it didn't gain much, people didn't like to use it because of the smell, I think, and the staining. So yeah, Dr. Dafitas would can comment on that.
Your comment daw, Belen?
Yes, we do have herbals, no, that are antifungal, anti-scabies, and Dr. Wang mentioned already, like cacahuate, no, is effective for scabies, and we compared it to permethrin lotion, and they were just as good. And then, of course, the Acapulco or Sena alata is antifungal and also anti-scabies. Yeah, it's just that when you make it into a lotion, the dried leaves, no, they have a brown color and they have a leafy smell. So I guess that has to be improved if ever it becomes a commercial product. But we have Acapulco ointment being made by Department of Health, yung pitak. And it's quite popular. It can be like sent to health centers even. And I encourage the use of these local herbals of ours, no? You grow it there in the backyard, you can make ointments, you can make decoctions and wash the body. And we have done this for tinea imbricata patients, no, among the indigenous people of the South. And it helps, it works. And also among the ITAs, I have used it also.
Ako, I have a few comments lang din for Belen. Kasi ang aking subspecialty infectious diseases in OBGYN. And what we found out is talagang there is an increasing rise in syphilis in our country. My question is, I think baka underreported kaya yung Yaws hindi siya masyadong parang in 33, parang yun ang nakita ko, 33 patients lang yung nakita niya. I think it's really more than that. And dapat siguro Luzon, Visayas, Mindanao, merong mapping na ginagawa. I'm sure our health secretary, Dr. Ted Herbosa, would be interested in making this the whole Philippines yung coverage. Kasi hindi natin ma-eradicate kung isang place lang talaga. That's my opinion. What do you think, Belen?
Yes, definitely. The Yaws were just beginning, no, to find out where the endemic areas are in the Philippines. So my studies were just, the tip of the iceberg. I have seen
Yes.
several cases in Mindanao, no, way back in year 2000. I saw a lot of cases then. So each province, no, especially in the Mindanao area, no, and especially sa mga indigenous peoples populations up in the mountains, we should be trying to recognize, no, and detect Yaws there because it's easily treatable. So that is part of the program we're planning for the country naman. No, it's already part of the plan that we'll be mapping out. We'll be going around doing a lot of
Oo.
education and training. Yun.
Yes.
So it's really a problem, no? Especially if you have we have had adults, no, that they were mistaken to have syphilis just because their blood serology was positive
Positive.
or Treponema pallidum. So ang automatic diagnosis is syphilis. But
Oo.
several people affected, especially in Mindanao, no, they were saying that we never had any like sexual contact. How can we have syphilis? So that's why the advice is if you know that you're in an endemic area for Yaws, no,
Oo.
and the person does not have a high risk profile for sexually transmitted infection, it's more likely that this person, no, had acquired Yaws in the past. Certainly in childhood, no, that's the most common time. So hindi dapat automatic na ay may syphilis ka, no, just because positive yung Treponema pallidum.
Okay.
Yes.
That's good kasi yun po ang sunod na question po Ma'am Belen. Kasi ang alam daw po nila pag treponema yun nga syphilis and then it's sexually contacted. So kaya po parang ganun yung kanilang understanding din siguro ng Yaws, ma'am. Okay.
Yes. So
Sige ba, go ahead, ma'am.
yeah, so I thank you for this opportunity to share nga this information with the public kasi it's so important na alam ng Filipinos na there's such a thing as Yaws and pwede siyang pagkamalan, no, as syphilis. Yeah.
Good to know. Good to know. Ma'am Stella, last question if you have.
Uh, uh, baka from the audience, baka meron pang question tayo.
I'm not seeing anything in the chat, ma'am. So I think we should be good. So again, thank you. Thank you po to our consultants po, no? Very, very, very important. Not every day that we have esteemed dermatologists who are really up to speed and really up to date at the cutting edge of the research, particularly for
Yes.
dermatology conditions and neglected
Yes.
tropical diseases of the skin. So here next po will be showing our evaluation poll here. If we could have that launch for the group already here in Zoom. So we are encouraging everyone to put in your feedback for these 5 questions that we have. I'll read them out and then hopefully everyone here will have almost 200 participants here will be able to participate. So thank you for those who have started. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. I'd like to also take this opportunity as our participants are putting in their answers po, no? We are being viewed both locally and internationally. So locally po, we have the Cagayan Valley Medical Center in Peña Blanca, Cagayan Province, Marymount Hospital in May Kawayan City in Bulacan, Municipal Health Office in Balete, Aklan, the Department of Education, Regional Office 5 in Bicol Region in Legazpi City, the Human Resources for Health under the National Health Workforce Support System, Malaybalay, Northern Mindanao. Maraming salamat po sa panonood. And Southern Philippines Medical Center in Davao City, in Davao del Sur. So not just locally, nakikita nyo po, no, nakikita po sa ating chat, but also internationally, we have attendees coming in from the Chonin Hospital in Taipei City, Taiwan, the Faculty of Medicine Travin University, Can Tho City in Vietnam, and those from Island Hospital, Penang, in Malaysia. So maraming salamat po to Dr. Enuina and Dr. Dufitas for this wonderful, very much informative po. No? It's something that I think we need to do a whole lot more in terms of dissemination and making everyone aware of scabies and yaws. For next week, Ma'am Stella, what do we have, Ma'am?
For next week, we have our speaker from orthopedics, Dr. Dave Dison, who will speak on spine problems, and also our rehab doctor is Dr. Jennifer Young, and both are very excited to have their talk with us.
Ayan,
Thank you very
okay.
much to Belen and Gwen. Also, very enlightening lectures, and I'm sure our audience has gained a lot of knowledge from this. No? So let's just continue what we're doing, continue your researches, and maybe in future, TVUP will have updates from your researches. Sa inyong dalawa, si Rowena and for Belen.
Ayan, thank you so much po. So before we conclude our program lang, Ma'am Stella, reminder everyone, all of our webinars are archived for viewing at the TVUP YouTube channel. So if you go to TVUP, sa YouTube po, no, you just type in in your app yung TVUP, meron po dong live na tab. Nandun po lahat ng 185 after today, 186 webinars na po siya. And then dun po sa part ng shorts part, is still in youtube.com/TVUPPH, you'll be able to see yung pong ating webinar shorts, which are maybe 1 to 1.5 minutes po, no, na short videos that we have. So this formally closes our webinar for the week. Makita-kita po tayo again next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.